Want to line up, and then you're just going to observe, your patient. And so basically, it goes anterior to the ankle, it goes slightly anterior to the knee, it goes through the greater trochanter, it goes through the lumbar vertebra, but it's not like you can actually see them because you've got tissue over them, right? And then it kind of goes through the shoulder joint, and then it goes to the external auditory meatus. And so in the notes, there is a slide that says these are the things that you need to be able to notice that way. And so one of the main things you're going to kind of get from this would be kyphosis, lordosis, forward head carriage, those kinds of things in terms of being able to make that postural analysis. So also in your notes there was that lateral position and the A to P position of things you need to make a assessment about. Okay. So, as I mentioned, there's no plumb line, so you have to be able to say this is where the plumb line runs, and say all the different landmarks that are used. And as I mentioned, when you're doing a lateral, go ahead and stand up more. So, to do a lateral thing, obviously you want to be able to look at the patient laterally. The other thing I mentioned in class, you want to have the person kind of stand, feet a little bit apart, close their eyes, and take a couple steps, and then just stand like you normally stand. This is not like stand at attention, because that's not how people normally stand. You want to get their posture. In a postural analysis, people don't stand like this. You're not getting actually information about cubitus varus or valgus unless you ask them to do that. So they're just going to stand normally. And so sometimes with neurological problems, when a person closes their eyes and do this, they don't know they're doing it, but they kind of end up like this. And that also allows them to kind of, they move around a little bit. One foot might come out a little bit more forward, because if they look down like this and get their legs lined up and then like that, that's kind of like unfair, right? So you just want to make sure that they close their eyes, take a couple steps in place, and then just stand, and that's how you're going to evaluate them. Now, as we're doing this as an exercise today, realize that you're going to have people looking at you and calling out all your faults. Oh, your head is forward, your shoulder's high, you got a kyphosis, your arm looks this, your shoulders look that, your waist looks this, your knees are locked, you got a fat foot. It can be a bit intimidating. So I just want to let you know, as people are making that postural awareness and analogy, not analogy, but description, you might be hearing all these things that, kind of sound like, ew. When you're doing this with your patient, you don't usually necessarily enumerate all that stuff, right? You're making mental notes of things that you see that are off. But for the purposes of today, it's valuable to say, I see a high shoulder, I see a forward head carriage, I see this, I see that. Again, most of the time if you're going to make some comment, it's usually because it's off. Or you might be able to say, oh, your head looks pretty good, your shoulders look fine, and at the end of the thing, you're like, oh, yeah, I'm all good. But, more often than not, there's going to be these, descriptions that are, kind of, sometimes might be tough to hear. So just be aware of that and realize that it's all done in clinical good faith. So as you're making this side posture, sometimes hair and all that kind of stuff gets in the way, but...
Is there any chance you could stand on the other side of her? Just so we can see.
So, what I'm looking for, because I'm making that, what do you call it, plumb line, but I don't have that, you're not going to have that in the test. She has an increased lordosis here, right? So, I could kind of, and you can, kind of feel the back. She has like a hypokyphotic curve here. It looks like her knees are locked. Her head doesn't look like it's really, too far forward. Those are some of the things that you can see in a lateral view, and then in an A to P view, which again, is in your notes, things that looks like this. I probably have to stand back a little bit, but the table's in the way. So I'm going to be evaluating, is there a head tilt? Is there a head rotation? I can't necessarily get that forward head carriage so well in an A to P view. One of the ways sometimes to be able to evaluate what's going on with the cranium, you can look at the eyes and see if they are equal, either in size or position, because sometimes a person's eye might be a little bit lower. You can also, with permission, put your fingers close to or in the external auditory meatus, and then see if they line up. These look like they're, on the same line, because sometimes they could be off a little bit, which could be because of a head tilt, It could be because of a disparity in the sutures of the skull. So these are other things that you're going to be able to start to make some observation about. So you want to get, what's going on with the head, what's going on with the shoulders. It looks like this is a high shoulder. And sometimes, interestingly enough, when I go around to look at the other side, it could reverse, and this one could look high from the back. I don't know why that happens, but sometimes it does. So, as I'm looking at the arms, they look pretty symmetrical in relationship to their contact to her body, although this hand looks like it's touching, and this hand isn't. So this other hand is out a little bit further. I mean, I'm exaggerating that, but it's one of the things that you can observe. I'm looking to see, are they both equally kind of like, I guess, forward rotated? Because what happens quite often is, the shoulders do this. So you can get that information in terms of that. They look pretty good. I might expect, if this is a high shoulder, this would be maybe a little bit shorter. But sometimes, there's optical illusions. It also looks like this clavicle is higher than the other clavicle. As I mentioned, it still looks like her her knees are locked. It doesn't look like genovarum or genovalgum. It can kind of also come from the back. To look this way to see if these things are still the same. This still does look like a high shoulder. Even in the back here, I can tell it looks like hypokyphotic, hyperlordotic. I can kind of check the crests, maybe find those PSISs to see if there's any kind of symmetry issue. And then to get to the point where you can evaluate the feet, you have to have a patient basically be barefoot, so you can really evaluate the arches. And to evaluate the arches, I can't really see anything from up here. So, to really do that, I need to kind of get down here. We'll do a little bit more of this evaluation of arches and stuff like that when we do the feet in whatever week that is. And so I'm kind of looking to see, are they fallen or not fallen? Are they symmetrical, not symmetrical? This one actually looks like it's a little bit more fallen than that one, so the white one looks a little bit more hyperpronated. One of the ways that it can look sometimes when a person has a flat foot, the analogy that I make, when you cook a souffle, it comes out of the oven, it's all nice and plump and up, and then, you come back an hour later when it's cooled off, it kind of sinks a little bit. Sometimes the feet just kind of have this, like, and they collapse, and so you get this appearance of,
I'm completely flat-footed.
You got flat feet? So when you look at Michelle's, can you pull your pants up a little more? So this one more than that one, but you see how this just kind of looks like it's, she's exaggerating it a little bit, but you can see how that has that appearance. So it's not just that she has flat feet, but they're collapsed, and so that's that overpronation kind of context. One of the ways, and we'll do this more when we study the feet, if it's flat when they're weight bearing, you can just have them take their weight off their leg, and the arch will come back. Or you can have them come up on their toes, and then their arch will come back if it's what they call a false flat foot or a supple flat foot. We'll discuss that type of stuff when we get to the feet. But those are things that, in relationship to doing the postural exam, that you'll need to be able to do. Be able to say, this is where the plumb line would fall, and then this is what I'm seeing in an A lateral position, and then this is what I'm seeing, A to P. You can either stand in the front. I usually do both, just to get a pretty good, idea. And you'll need to make a comment, and this is in your notes, so I don't need to worry about it right now. You need to make a comment about the head. You need to make a comment about the shoulders. You need to make a comment about the upper extremities. You need to make a comment about the spine. And I didn't say anything specifically, but you need to make a comment to some degree about the scapula. Now, usually if you're doing a postural exam on a patient in a clinical situation, they'll probably be in a gown where you can actually see the scapula. Or if it's a male, it might be disrobed and just have pants on or shorts or something like that, and you can kind of more easily see. But if you can't see, you can usually also just come up here and kind of palpate and say, well, it looks like the superior medial angle or the inferior angle seem to be symmetrical or not, or one's winged or not winged. You get that information. This is what the pelvis looks like. This is what the lower extremities look like, particularly the knees and the feet. Now, also with the feet, they're both Lawrence are both pointing straight ahead. Sometimes what you'll see is external rotation. It could be asymmetrical or it could be symmetrical. Or you might see internal rotation, either symmetrical or asymmetrical. So that's going to usually give you information about the internal or external rotation of the hip. Because this kind of stuff is not really a foot issue. This is, a lower extremity coming from the femur through its articulation with the tibia that makes this happen and that happen. All right. So again, that is in the notes. It says these are all the areas you need to make, some assessment on. And so
are we going to actually palpate?
You can just say,
okay,
just like that, you can get a sense of kyphosis, lordosis, scoliosis. The idea is that when you evaluate a patient who has a musculoskeletal complaint, it's valuable to know what is their posture like. And as we talked about in class, there's upright posture, there's seated posture, there's lying down posture, there's kind of correct lifting kind of circumstances. So, what's their job? What are they, what's going on with them? Because quite often people have stresses in a postural context that are perpetuated. Sometimes an injury, because of an injury, they then develop bad posture. Sometimes because of bad posture, they're more susceptible to injury because they're biomechanically not necessarily unstable, but just not balanced, right? So then you can get that sense of this is what's kind of going on. And the simple correction, is basically muscular in many respects. Because usually there's some muscles that are over tight and some muscles that are over weak. And the over tight muscles kind of pull the shoulder up. And so you need to kind of relax those. Maybe other muscles you need to strengthen. And so you can start to get that sense of, well, when I'm evaluating this person's talking about neck and shoulder pain, they have high shoulder. So something's going on in this, thing. So you can check trigger points. You can do various other types of soft tissue things that we learned. You can do manipulation, because if structure governs function, right? So you can kind of shake it up a little bit in relationship to the manipulation. To make those kinds of corrections. And also, this is the kind of thing that down the road, patients need to have that awareness of, yes, I do have high shoulder, my posture is really crappy, and so I need to kind of make some changes. And then yoga is very helpful, particularly for the spine stuff. I would imagine, though I don't have a lot of experience with Pilates, but many, Feldenkrais is Alexander technique. These are bodywork type techniques, massage, that are very helpful to help, identify postural imbalances and help to strengthen, muscles and different things like that. And that person's like, yeah, I feel better and stronger, and so on and so forth. And then, again, if they have inflammatory type conditions or injuries, that lead to that. Maybe this person, in the past had a frozen shoulder, and that's one reason why it's kind of up like this, But these are kind of some things actually you would expect to some degree to elicit from a history, right? So anyway. And so you can now, partner up or 3 people up